Welcome to this presentation on the addiction treatment market, roadblocks, opportunities, and future trends. As we enter 2022, there is a very, very strong interest in behavioral health and addiction treatment in particular. With COVID, we've seen a large uptick in need, but as we'll show you, that need is actually perhaps not as large as people have imagined it to be. If you're in the addiction treatment space in particular, you've probably heard that it's anywhere from a 35 to a $45 billion industry in terms of market cap. That is inaccurate. There are quite a few inaccuracies when looking at the field in terms of the potential, the real roadblocks that exist, and what the opportunities are. A lot of people have tried to build successful organizations and a lot have failed. Right? We've seen American Addiction Centers go bankrupt. We saw Elements Behavioral Health, Sovereign Health, Morningside, Solid Landings. All these facilities that tried to grow have ended up going bankrupt, and we see that with the smaller providers as well. So my name is Nick Jaworski. I'm the CEO of Circle Social Inc. We are a strategic marketing and consulting firm strategically for behavioral health and addiction treatment. As far as I know, we have more data than anyone else in the space. So at this point, we have about $2 billion worth of operating data, and then 350 million of that is specifically related to marketing efforts. So we understand the space across geographies, across levels of care. We work with psych hospitals, traditional addiction treatment clinics or drug rehabs, MAT clinics, and outpatient facilities at all levels of care. So we have a very broad overview of what this space is, and this training will give you our insights into where we think the macro trends are, what the market cap is, and what the real potential opportunity is, as well as some thoughts around why a lot of previous and actually existing providers have not been as successful as everyone kind of assumed that they would be, and we'll correct some of those assumptions throughout the presentation here. The first place we're going to start is actually the need. So a major assumption within the addiction treatment market in particular is that there is a large and growing need for addiction treatment services. That is actually inaccurate. So this is SAMHSA data here, right? Substance Abuse Mental Health Services Association. It's a government entity that does a lot of data and tracking around substance abuse and mental health issues. And as we can see here, if we look at the red line, that is for alcohol or illicit drug use disorder, so really SUD. And this data is a little old, but unfortunately, after 2014, SAMHSA changed the way that they did the data analysis, and so we don't get these combined rates in future data sets, but we'll look at what the kind of comparable data is. So we see that overall, there was, starting off in 2002, we had a 9.4% rate of SUD, and SUD again includes alcohol as well as any other substance use disorder. So they're combined. And that's the way that the payers think of them as well. So we have a lot of conversations with the heads of behavioral health for Anthem, Cigna, Gel, and other providers, and they categorize it the same way as SAMHSA does. We can see that that dropped to 8.4% by 2014. And then if we look at newer data here, and we look at it from an age group standpoint, right, we can see that percent of patch use in the past year is very, very high among younger generation, 18 to 25. So very high use there. But if you look at the older generations, anyone over the age of 26, it hovers around that lower benchmark. So that's important. We'll come back to that later. And then here we have percent with substance use disorder again in the past year. As we can see by age group, high for 18 to 25s, but then after the age of 26, we get down to the 6% range. And that's really where we're at in 2019. So if you look at 12 or older as the red line, so that's including all age groups. So all age groups from 2015 to 2019, if we average that out, is a 6% rate of addiction. Now things have actually changed here in 2022. SAMHSA is using the DSM-5 instead of the DSM-4 for criteria analysis. And that has actually radically changed and broadened the range of people that fit in the SUD. So if you look at today's data, you'll actually see a double, about obviously anywhere from like 12 to 14% in terms of the newest data. But that is because they've changed the definitions of what classifies as an SUD and really broadened it, similar to what happened with autism as we moved into the DSM-5. So different definitions have changed this, but if we look at that previous definition, which was pretty consistent for a long time, you see an average rate moving from 9% way back in 2002 to 6% in 2019. And so what we're seeing is obviously a drop in the overall rates of substance use disorder within the United States. It is not increasing. This is something that people often get confused with. and at the same time, it's stable. So even though we're seeing, increase in utilization perhaps a little bit, especially with COVID, at the end of the day, the rate of the general population that's searching for SUD services is dropping. Um, and on top of that, what we want to think about is while that's dropping, obviously the population is also fairly flat. So if we were having population increases, we could then assume that even if that percentage of the population stays the same, we might have more opportunity within the addiction treatment space. However, as we know with the last census, we actually are sitting around 330 million in terms of the population. So that hasn't changed. So there is not increasing opportunity within the SUD space. It is very flat and for the most part probably dropping. Now, with the expanded definitions within the DSM-5, does that mean that there's more opportunity to obviously bill services? Perhaps. Our argument would be no. At the end of the day, most people aren't looking for services, and we'll talk about that in a second here. So just one more data set, just purely alcohol use disorder. And so this was not provided by SAMHSA. This is actually provided by another organization that was studying HIV. And then they also looked at alcohol use disorder as that was associated with it. So again, you can see it broken by age group. So if you look at the 18 to 25-year-old age group, very high. So they're as high as 17, 18% way back in 2002. That has steadily and significantly decreased. So 2018, when they had the last piece of data, down to 10%. Again, if we look at the overall 12 or older, so everyone really, is the red line. And again, we see a similar data set that we saw with SAMHSA. So starting around 8%, dropping down to about 6% by 2018. So very, very consistent in multiple data sets from different organizations in terms of the overall rate of substance use disorder within the population. Also very, very important, we'll talk about in a second here, the high rates among 18 to 25-year-olds and then the significant drop-offs after the age of 26. So what that brings us to is the opioid crisis and how that affected the substance use disorder addiction treatment space. We can see here that the rate of overdoses and deaths from overdose significantly increased from 1999 to 2017. And then as many of you know, in 2020, we had one of the highest rates of overdose deaths ever, over 100,000. So that, more than doubled from 2017 to 2021. So that is obviously upsetting. It does show that there is a strong need to reach people before they overdose. But going back to that previous data set, there is a disconnect here, right? Or a misunderstanding that often comes into play. So overall, the rates of addiction are not increasing. However, rates of overdose are. Why is that? It's really related to opioids. So the potential to overdose on an opioid is much, much higher than marijuana, than alcohol, than cocaine. And so the primary drugs of choice that people are using are very much defined by access. And access means obviously physical location, how easy is it for me to get access to it, and cost. And so when we look at drug trends in the United States, it really depends on what drugs people have access to. And so, in the 70s and 80s, when people were mainly drinking or smoking pot, for example, even using some LSD, you're not going to overdose on those. Whereas as that switched to opioids with really the prescription pill transition, we saw a massive increase in overdoses. And so one of the reasons that people switched to opioids was, again, access in terms of location and cost. I could get a prescription pill almost anywhere because the market per se was flooded with them as every single doctor in the country was able to prescribe opioids. Also, it was the lowest cost. So rather than having to go to a street dealer and buy my bag of weed or get a bag of 8-ball of cocaine, I could go to my doctor and get a fairly legal prescription, right? And then there was so much overflow that I could get from friends, I could get from family, lots of opportunities to get a hold of opioids. So low cost, free, right, or close to free, and then available at your nearest pharmacy. Especially in rural areas, rural areas often struggle to get access to illicit drugs. And so having the opportunity to be able to go to a local doctor and get a prescription really allowed the opioid crisis to explode in rural areas where that opportunity did not exist before with some other drugs of choice. So this really propelled an increase in the addiction treatment market during these years as there was massive fear among parents, particularly mothers of 18 to 25-year-olds. And then, as we saw before, the 18 to 25-year-olds are the largest users with substance use disorder, and that holds for any disorder, whether we're talking about opioids or marijuana or cocaine. And again, drugs of choice tend to trend. So depending on what's available in a given year or a given decade, that's what people are going to be using. And so since opioids were easy access, low cost, that's what we see a lot of the younger generation starting to use in these years. And so unfortunately, we see a massive increase in deaths. And then obviously on top of that, we have the synthetics. So you have your fentanyl and your carfentanil, and those are very easy to overdose on. And also, unfortunately, they're cut into a lot of things. So maybe you're getting some marijuana, maybe you're getting some cocaine, maybe you're using some meth, and it tends to be cut with small amounts of these synthetics. And that also leads to overdose because they have such high levels of potency. And especially if you mix, a lot of users are polysubstance, right? Very few people just use one drug. They'll tend to use whatever they can get a hold of. So for that reason, when they're mixing drugs, it increases the likelihood of overdose. So we saw this real strong fear move into the marketplace, and then that combined with Obamacare and the Affordable Care Act. So as Obamacare and the Affordable Care Act came into play, it then covered children, adult children under the age of 26. Before Obamacare, most people under the age of 26 did not have access to good insurance. They're working in hospitality or retail or fast food. They're working part-time jobs as they go to university. There's just not a lot of access to good insurance. And so they weren't able to go to these high-cost addiction treatment facilities, especially on the residential end. That all changed with Obamacare. And then suddenly you're under your parents' policy, which, they probably have a career or they work for a union. And so you're covered under some decent insurance. So that massively increased the number of patients entering treatment. As we'll talk about a little bit later, people tend to not enter treatment until a little bit later in life. So getting the younger crowd in, and the young crowd doesn't want to go, right? If you think about someone in high school or college and alcohol and drug use, they are not motivated to go into treatment. However, mothers are, especially with the opioid crisis and the risk of death. So lots of impetus, big pushes from mothers to get into treatment, and that changed the overall addiction treatment landscape. Comment on that component then. So there was an influx of patients, even though you only see the same rate of people struggling with addiction, that's actually shrinking, right? We went from 9.4% to 6%, so less people struggling with addiction, but we did see a higher number of people utilizing addiction treatment because of that push by mothers. So we all look at the market cap for addiction treatment services to really start to understand what the available opportunity here is. We can see that here in 2020, we're spending $238 billion on mental health services per year. $42 billion of that is substance use disorder. However, if we look here, we can see that for a specialty substance abuse center, which is a drug rehab, this also includes MET clinics, is 33% of overall spending. So 33% of the $42 billion in spending is just $13.9 billion. And that's the real market cap that's available to substance use disorder providers, drug rehabs, addiction treatment providers, again, across levels of care. So if we're talking about residential, PHP, IOP, outpatient, OP, and MET clinics. And we'll look at in a second that utilization rate for the most intensive levels of care is obviously the smallest. The fewest amount of people are accessing residential levels of care, which is where a lot of the investment has been traditionally within the drug rehab space. So the smallest part of the market is where a lot of investor interest and growth potential has been focused, and that's not really the area where the most of the patient volume is coming from, though there is an obviously opportunity for higher revenue because you can charge $15,000 to $60,000 a month depending on the kind of care that you provide at the residential level. So again, just very important to understand that cost breakdown, and that we're only looking at about a $13.9 billion market for a specialty provider. The vast majority of the spending goes to prescription drugs, it goes to hospitals, it goes to office-based professionals like standard therapist or psychologist. Most people will seek that level of care before they go to a higher level of acuity. So treatment utilization within the US obviously sets that market cap. So as we discussed previously, about 6% of Americans struggle with an SUD, according to SAMHSA. That's about 20 million people, 4.5% with an AUD. But remember, An AUD is a subsection of SUD. So these are not cumulative. We're not adding them together. It's just a pullout from the 6% total. So we have 20 million Americans struggling with an SUD or AUD. But according to SAMHSA, only 11% of those people struggling want treatment. And this is where one of the major misassumptions has been for a long time in the addiction treatment space, this idea that there's some kind of blue ocean opportunity of this other 89% of patients that are not seeking care. It is not the fact that patients don't have access to care or don't know that care exists. When SAMHSA surveys patients, and I can verify this from being in hundreds of centers myself and talking to hundreds and hundreds of patients over the years, patients do not want to seek treatment. The vast majority of people struggling with addiction are not interested in going to treatment services, and they are especially not interested in going to a high acuity service like a residential, where they have to pay thousands of dollars for a deductible, spend at least 30 days of their lives away from family and work. There's a very small minority of people that are willing to make that financial and time commitment, especially as one gets older. Again, going back to the opioid crisis and moms pushing in the adult children, moms obviously had a lot of influence there. These are children that often were failure to launch, so they didn't have a job, they didn't have resources, and so they have to kind of listen to what their parents want if they still want access to live with that person and keep that relationship and maybe keep a financial incentive, right? The family supporting them. So there was an increase at that point. But for the most part, only 11% want treatment. So that's only 2.2 million people across the entire US in a given year that are going to seek services. And again, that's across the board, right? It's talking about Medicaid, Medicare, commercial insurance. It's not nearly the number of patients that I think people thought is available in the market. The average number of treatment episodes, according to Bill White and a lot of the research that he does, Bill White's a very famous researcher in the addiction treatment space, very well respected. He sees about 3 to 4 episodes of treatment in an 8-year period. So most people do recover. Recovery is very possible. There is a misassumption that addiction is kind of a chronic, progressive disease. We don't see that in the data. That's really a misconception in the field. And same thing if we look at that age data that we saw before, the largest number of people struggling or labeled with an SUD are the 18 to 25-year-old demographic. Then suddenly at the age of 26, that drops by more than half. Why does that drop by half? Well, people walk away from addiction. They get careers, they start to have families, they start to get serious about their life. I'm sure many people listening to this presentation can relate to that. Probably had some crazy times in college, and as you got older, you just walked away, and that's what the vast majority of people do. So addiction is not as sticky as a lot of people think. There are obviously a small subsection of people that really struggle and are high utilization, just like in any kind of healthcare setting, right? We have our high utilizers, but for the most part, most people either walk away on their own, and if they are continuing to struggle, it tends to be 3 to 4 treatment sessions in an 8-year period. So 80% struggling to recover on their own. That research has been conducted for quite a few decades now and has been consistent. So the most people that are identified by SAMHSA and NASARC and other surveys that are conducted out there, most of those people do not seek formal treatment in any way, shape, or form, and do or have what's called a natural recovery, where they walked away on their own, they found meaning and purpose in life, they found other resources where they did not need formal treatment. And just some other background here to help people really understand and combat some of the misconceptions that occur in the space. According to NIDA, which is National Institute for Drug Abuse, run by Nora Volkow, she does a lot of this research. Only 2% of individuals that were prescribed an opioid get addicted to that opioid. Very big misconception in the space that opioids are highly addictive and that the drugs are hijacking reward pathways in the brain. The reality is it's not really the driving force. It's not the primary causal factor within addiction. Obviously, drugs do have big impact on dopamine receptors and serotonin and the way that the brain works with the mesolimbic system and the reward system. However, this interplay with those neurobiological elements is not a driving force. It really is a lot more to do with environment, life situation, coping skills, etc. So the drug is not a critical element of that component. And as we've seen before, really addiction rates in the U.S. have been flat. They've just been super stable for 2 decades now. Um, so what we do see is people changing the drug of choice, but that has to do with access, not the inherent addictive nature of the drug per se. So 2% get addicted to an opioid if prescribed. That number does change. It does multiply by 4, right, to 8% after 3 months. But there's obviously some obfuscation in the data there. It's compounding factors. People that are using opioids for a longer period of time, very high likelihood that they were leaning towards an addictive behavior earlier. So there's a certain level of choice, perhaps, that's happening there. People, or let's say prevalence, people are more likely to use longer if they have a previous kind of underlying addictive approach to substance use. And we see this pretty consistently. So when you dig down into people that are struggling with an opioid prescription from a substance abuse standpoint, the vast majority of those people already had some kind of indicators. They were already struggling with alcohol or marijuana or meth or another drug. It's a minority of people that just start off with the opioid and then continue along that path. Most people are trying something else. So again, opioid use really depends on environment, coping skills, culture, a lot of the other factors that will drive longer term use, which then can potentially become addictive use. So who seeks treatment? Very, very important to understand, right? If we want to understand the addiction treatment space and the opportunities that exist within the marketplace, we do have to know who's actually looking for treatment, because as we saw, only about 11% of people that are labeled with an SUD actually seek out treatment. So the reality is that it's more male than female. So again, if we look across all of our clients, if we look across the country, this is really consistent. About 70% of patients in treatment facilities are men for SUD. 30% are women. Now, that is not connected to the actual overall population prevalence. The overall population prevalence is almost 50-50. The number of women that have been struggling with SUD has actually been increasing as a percentage of the population year over year. So it comes out to like 55% male, 45% female, but so pretty close to 50-50 these days. However, males' likelihood to actually seek formal treatment is higher. Why is that? I don't have any firm data on that. It's really supposition. But from what we see, women are just more stigma. They're less likely to seek treatment. They also have stronger social networks, and so they're often probably able to recover on their own more through the social support, the connections that they have. Men tend to isolate more. And so isolation is really a key component in what drives addictive behaviors. And so if you're having more men isolate, they're more likely to have severe acuity, which means that they may need professional help rather than be able to walk away on their own. So 70% male, so most people are targeting a male. Now, that doesn't mean, for example, from a marketing perspective, that you're trying to target men. This is actually a big mistake that a lot of providers make. Still, the most people that are calling into the facilities are the loved ones of that individual, and very often they're women. Almost 80% of the time, it's a woman calling for, a husband, a son, a father. Even when it's other women involved, if it's a daughter or a sister, it usually tends to be another woman that's calling. There's not as many self-admits coming from the addiction treatment space, which is very different from behavioral health in general. A lot of people do self-admit for depression, anxiety, OCD, etc. But SUD is very, very different. And it does depend on level severity and income level and things like that. So we do see a higher propensity for individuals to call for themselves for a self-admit standpoint when they've really reached a very, very high level of acuity and they've burned all their bridges. So they've burned bridges with family, they've burned bridges with friends, they've lost their job, they've lost their money, they've lost their insurance. And unfortunately, at that point, right, they're not able to access care as easily because they don't have the financial resources, either through insurance, through an employer, or through family support. So at that point, it's much, much harder for them to actually access treatment. Where you want to really reach people is where they are still employed, obviously, right? They still have not burned all those bridges. They have some kind of family support system. So you're looking to reach a lot of women with male family members who are struggling. Young SUD patients are a different subsection, as we've talked about. They are really the 18 to 25-year-old demographic, and you'll see that extend up to 35. So even when you have younger married couples or older parents, right, looking at a son that's working in the trades, or maybe it's a small business owner, um, they are pushing that older child into addiction. But 18 to 25 is really the most common age, and then the whole 26 to 35 is a different subsection. But these are really moms. These moms, and they're especially individuals that are struggling with opioids in general. So again, if we go back to our data about what people use and why they seek treatment, think about it in your own life. If you have a son or a daughter, or even think of maybe your own use at one point in time. If it was marijuana, you know, adult child comes home smoking pot, there may be a conversation there, right? The family may not be happy about that situation, but the likelihood that they're going to say, okay, you need to get into a treatment center as fast as possible, and we need to, find a solution for this addiction that you're struggling with is very small. Even for alcohol, it's pretty normalized within U.S. culture in particular, and so someone gets a drunk driving or they come home drunk. Again, conversations there, but the likelihood that you're going to push that person into treatment is small for the first time. Whereas if it's opioids, especially if it's heroin, very high level of anxiety, right? Very high level of stress. They want to get that person into treatment immediately at the first indication of use. So we see a lot of moms pushing adult children in for opioids in particular. You'll see a little bit of cocaine use, but cocaine use is just much smaller in the population in general. And there is just not the level of fear. People are more scared of cocaine than they are of marijuana per se, but you're still not as worried about overdose as you are with an opioid. So reaching mothers and other women that have an adult child or a husband that's struggling with opioid use is a very strong segment of patients entering care. These patients do tend to be, like I said, male, under 35, middle or lower class, high school education, maybe some college. It's often called failure to launch. These are adults that have not really been able to be successful, to be independent on their own, whether it's in terms of getting a job, completing college, moving out of the parents' house, whatever it is. Um, Very strong struggle there. And again, they do tend to be middle or lower class. So addiction does affect obviously all income levels, all socioeconomic status. Anyone can struggle with an addiction, but the operative word there is can. The reality is that prevalence is much higher the lower you go on the socioeconomic ladder. And that again goes back to all these environmental factors we mentioned in the beginning. It's stress, it's culture of use in the community, it's coping skills that people learn growing up. Lower socioeconomic status tends to not have the same level of community coping skills taught to children while they're growing up. So also support networks, right? In lower income communities, there's a lot more stress. Sometimes there's not as much support as there possibly could be. And there's just not the same access to care and preventative services and things like that. So we see a higher rate among those income demographics. Then we have older alcohol use disorder, and this is really often like 35 plus. So as individuals get older, especially with alcohol use, they will start to seek care. Alcohol use is more accepted, right? And so it's very possible to use a lot of alcohol but still function very well in society, to be accepted with heavier levels of use even within the family. So we don't really see older individuals seeking treatment for alcohol use disorder until they've had a decade or two under their belts and the problem has gotten quite severe. If someone's having a beer or two a night, that's normal in a lot of areas. No one's really concerned about that. But if that progresses to suddenly, a fifth of vodka or half a bottle, or they're getting blackout drunk every single night, drinking a 12 pack of beer or something like that, um, then at that level, they're very much looking to seek treatment. Again, pushed in by family, sometimes on their own. So those are your two main demographics. You will see people enter treatment for obviously a whole variety of drugs and addictions, but the vast majority are really younger patients with opioids or older patients with alcohol use disorder. Um, Even things like meth and cocaine is much a smaller subset of patients entering treatment. And those patients often are again, polysubstance use, right? So they'll also be using opioids or also be using alcohol. Across the US, about 50% of our patients are alcohol use disorder, and we see that consistently. That's been that way for decades. So if you talk to any addiction treatment provider, one of our clients or not, you will see it's a 50% rate. again, who are alcohol use disorder patients. Again, tends to be male, just skews that way. And again, remember, this is people entering treatment. So if we look at alcohol use disorder, male versus female in the general population, it's closer to 50-50. But the people entering treatment are more likely to be male. They are more likely to be divorced or widowed. Again, going back to the isolation component, the lack of a social network, usually high school education, maybe some college, very strong propensity to be employed in a trade, um, working with a union, some kind of maybe construction jobs are big, but any kind of job that is less, we see it less within white collar. It tends to be more blue collar that are struggling with these use disorders. And again, you will see, absolutely see white collar workers struggling with alcohol use and substance use disorders, but it's just a lower prevalence. They are employed, obviously, because they've got insurance to be able to go into treatment, and then median income is around 45,000 a year. We covered this already. Lower socioeconomic status as you move down, higher propensities for behavioral health and addiction issues. I do want to point out that the majority of use, especially for illicit substances, occurs within the urban setting. This goes back to access again. So it's much, much easier to get access. If you're a drug dealer, you want a market where it's easy to sell to people, you want high population density, you don't want to drive out into the sticks and sell to 5 or 6 people out there. So it's just an access and kind of an economics issue in terms of what people are able to get where. Really good examples, like we'll see this in more spread out rural states like Montana. So Montana, it's a 3-hour drive between major cities, and during the winter when roads get tough and there's a lot of snow, like drug access will just dry up because no dealers are willing to go out there, no individuals are willing to make the drives to the bigger cities to get things and bring them back. And so we see a lower rate of use overall in rural areas, with, again, the only difference being opioids, because prescription pills had a very strong supply chain, right? The pharmaceutical companies, the PBMs, everyone had made these really strong supply chains across the country where you could get prescription pills in anywhere. So at that point, because the access was there and the cost was low, we saw a much, much higher propensity of use for prescription opioids and opioids in general within rural areas compared to urban. So you will see, actually very successful MAT clinics can open up in an urban area, if there's a high enough patient population, because that was the only drug that they had access to. And a lot of people want to get off it at the end of the day. People don't like opioids. Being addicted to opioids is much more painful than other substances for the most part, and getting off them is much more painful. So usually people are willing to seek help. And just small comment on special demographics. Obviously, there are different professions that are more likely to use it. Again, it tends to be like union workers, trades, anything that's hard on the body, right? Construction, maybe warehouse work, anything that where you have to really do a lot of movements with your body that wears it down over time. There's a higher propensity to use alcohol or other drugs to relieve that pain, as well as this is a high level of stress, right? At lower income levels, higher level of stress, so you're more likely to use alcohol or drugs as a additional coping mechanism. Well, 40% of veterans struggle with alcohol use. Um, doesn't necessarily mean that they're labeled with an SUD, but there is a high propensity to really use or overuse alcohol among veterans. So you can see a higher population there. And then LGBTQ is another one, about 12% prevalence. So again, if we look at our data, it's about 6% in the overall population. So it's about double with LGBTQ. Again, goes to stress, right? So a lot more stressors, a lot more negative impact growing up LGBTQ in the U.S. in terms of acceptance and ability to go into the communities and be open about who they are, and trauma and everything associated with that. And then also there's a cultural element where drug use is much more normative in some LGBTQ communities than it might be in the general population. So we do see higher rates of use there. But these are small demographics at the end of the day, right? The percentage of the population that are veterans, the percentage of the population that are LGBTQ is much smaller. So it's very, very hard to build a program or a track around these demographics. It's much easier to build a general population. Then maybe you can have a specialty program if you're in an area that has high density of individuals coming from special demographics. But for the most part, especially even if we look at like high-end providers, let's say you want to run a specialty program for pilots or EMT or lawyers, for the most part, you're not going to be able to survive with a program like that in a single area. That kind of program is really going to have to build a network of referral partners across the region or across the country, or with trade organizations, right? So maybe you partner with a pilots association, you partner with a licensing program for nurses, and they will refer a larger patient volume to you from across the state or sometimes across the country. That's really the only way for those types of programs to be financially viable. So looking at the market cap for the addiction treatment space, just in commercial insurance. So again, this is where the vast majority of providers have been, over the past 2 decades here. And so looking at what those numbers are, about 67% of the U.S. is covered by commercial insurance, which is 221 million people. Now, according to the payers, and this is proprietary payer data, so I can't give specifics on it, but I can just tell you that conversations that I've had with multiple payers in terms of utilization rates range from 0.5 to 1.5%. So about 1% on average, across different payers of commercial policyholders use their policies for substance use disorder treatment in a given year. Now that is for all substance use disorder treatment. So as we saw in the beginning when we were looking at the market cap, sometimes that's being utilized for hospital ER visits. A lot of the times that's being used for outpatient visits to a psychologist or a therapist. And the minority of that percentage is then being used for higher acuity levels of care. When you talk to the payers, very, very consistent. Highest utilization is outpatient. Then next highest would be intensive outpatient, then PHP, partial hospitalization, then you have residential. So as you get to a high level of care, there's a smaller and smaller percentage of the commercial insured population that are utilizing those services. So just kind of pulling from that market cap data, again, this is rough estimate, right? Because they're looking at total cost, not total patient volume. But however, as a rough estimate, we'll say that 33% of those specialty providers, right, see the commercial policyholders. And then really 33% of that is going to the detox res level. So we have the smallest number of patients going to the detox res level, again, coming from payer data, just from our personal relationships that we've had, and getting access to that data and verifying it with the heads of substance use disorder within the larger payers. So you only have about 239,000 people per year accessing detox res levels of care with commercial insurance. Now, about 20% of those, it's between 10 and 20. Better providers actually have lower rates, obviously, but about 20% will use their policy again in the same year. So while you have 239,000 unique individuals with commercial insurance using their policy for SUD treatment, you have 20% of that 239,000, so about 48,000 will use it at least one more time. So as we saw, people tend to have 3 to 4 treatment episodes in an 8-year period, but the highest propensity for relapse or reutilization of services is within that first 12 months. So if we add that 239,000 plus the 48,000, we get 287,500 roughly treatment episodes per year at detox res levels. So again, very rough, right? But if we just divide that by 50, we get 5,750 per state, or 479 per state per month. So obviously higher population states are getting a higher percentage of that, but just doing a really crude estimate, that's a good way to break down the numbers. So let's say that we want to run that for Indiana. So our company's based in Indiana, and so we'll use it as an example. But there's a population of 6.7 million people, and then 67% of those are commercially insured. 1% of those are using their policies for SUD, and then another 0.33% are using it for a specialty provider, right? So if we multiply all that out, we get 4,888 per state, or for Indiana across the state. For the year, that's 407 per month. And again, just a smaller percentage of that is going to detox res levels as well. So when you look at the potential volume in a current state, I mean, really we can only service about 400 patients per month. Now again, it can be a little bit higher, just because people might use multiple times. You have people being pushed into care that are doing private pay that aren't showing up on insurance. So you'll see anywhere from 2 to 5% of patients entering treatment are coming into private pay rates. And then some providers take Medicaid and things like that. So changes the number. But if we're looking at Indiana, based on the way that we run this formula here and potential market um, opportunity in terms of the addressable market, there are only 400 beds that the state can really fit. Again, you can have patients come from other states, and there's a lot of little factors in here, but there's just not as much volume as people really thought there were for residential levels of care in particular. So if we run those numbers, we say, okay, look, there's 287,500 treatment episodes per year at detox res levels. The average reimbursement for that is, let's say, 15,000 if we're on in-network policies. So again, lots of out-of-network and network conversations there, but we're just going to do some crude estimates. We'll say there's about a $4.3 billion market for detox residential for the commercially insured. Um, that's not that high, right? At the end of the day, the market is not nearly the size of what I think people assumed it was. If we look at an average reimbursement rate for PHP IOP, we'll say 8,000 per patient. Again, in-network rates, if we assume that's the norm, which is really what most providers have moved to, that comes out to about $7.8 billion. So when we really look at the data in terms of the total market cap, again, we've got that, 287,000 treatment episodes per year at the detox res level. And if we assume an in-network rate, we're just going to use in-network rates. Obviously, it's out-of-network providers, and they get much higher rates. But at the end of the day, let's just kind of use 15,000 as a really crude benchmark average. That comes out to $4.3 billion per year as a market cap, total addressable market for detox res across the U.S. in a given year. PHP IOP, let's say $8,000 is standard reimbursement. So that's $3.5 billion in terms of total market in a given year. If we add those together, we get 7.8. So about $8 billion of a commercially insured SUD market in any given year. Much, much smaller than, again, the 35 to 45 that you'll often hear. But that does line up with what SAMHSA sees in terms of total spend for specialty providers. Obviously, that's just $8 billion. The other money that we'll see is coming from Medicaid in particular and MAT providers. And just kind of so you guys understand, really you're looking at 20 to 30% margins within traditional rehab space. So especially at those levels of care from detox to IOP, 20 to 30% is a pretty standard margin for in-network providers. So then we've got Medicaid overall. What does that look like? So in 2018, we had 55.9, so about 56 million citizens were covered by Medicaid. 8% of those were treated for SUD. So now remember, right, when we're looking at who is accessing services and who needs services, when we looked at the commercially insured, only 1% of the commercially insured are accessing their policies for SUD. For those on Medicaid at lower income levels, 8% are accessing them for SUD. So this aligns with all the research data that's been out there for decades showing that, higher rates of addiction occur at lower socioeconomic status. We have about 4.6 million potential patients in a given year treated for SUD. And it also shows that there's a higher level of access, right? Or a higher level of treatment-seeking behavior among those on Medicaid. So we're just seeing a higher utilization of individuals seeking out treatment at that level. And again, this kind of goes down to just the need to seek treatment often occurs the more difficult life has become. And so obviously if you're at a Medicaid level, it's probably a pretty difficult life, right? You don't have a lot of money, a lot of other problems going on. Usually there's additional health issues, etc. So there's a higher propensity to seek treatment with additional stressors in the life. So just looking at some Medicaid data that's provided by the government in terms of utilization. So obviously you have the percent SUD. Well, 42% of those who seek treatment seek inpatient service. And inpatient service, in the way that Medicaid views it, is detox. So detox is really 3 to 4 days. Maybe you're getting $300 per day, a little bit more. Really depends on the provider. So it comes out to about $2 billion a year of individuals seeking detox services in terms of the total addressable market. Now, there has been a big shift, and we don't have a lot of data on this yet because it's very new. So Medicaid traditionally did not allow residential reimbursement on Medicaid. So most people on Medicaid could not seek residential services for SUD. And so there isn't really existing data, at least that we've found, to show what those utilization rates are now and what reimbursements are. So what we see with providers in our network that we have clients, where they get about 6,300 and about an average length of stay of 21 days for a Medicaid individual. And again, it's very new. So that is probably a blue ocean right there. Most people do not accept Medicaid in this space, but there's a huge opportunity to be able to expand providers that accept Medicaid. One of the challenges there is the cost structure. So most for-profit, even nonprofit providers that are currently accepting commercial insurance or private pay, they have a cost structure where they're paying, $400 or $500 per bed per day just to operate. Well, Medicaid is only going to reimburse, somewhere between 250 to 330. And so it's actually more expensive for existing providers to deliver services to Medicaid than they get reimbursed. So they're actually not set up from a cost structure standpoint to be able to be profitable. Now there are, right? There are some good providers in the country that are set up to take Medicaid, and those providers can operate very successfully at $250 to $300 a day. And so those providers have the greatest opportunity in terms of what we see across the country in terms of expanding network and market share. So again, going back to Medicaid data, 75% received at least one outpatient treatment episode. Again, higher utilization among outpatient care. And then 26% received inpatient, then outpatient within 30 days. 46% went to the ER. Emergency room visits are really a standard or a staple among individuals on Medicaid. 42% went to detox, as we talked about. Now only 6% went to residential. Again, as we just discussed, that's going to change. That reason was because it wasn't available, was not an option for those on Medicaid for a long time. So there really is no service infrastructure to help people from a residential level until quite recently. Just understanding the breakdown of what the primary drugs of choice look like. Of the 4.6 million treated for SUD, 31% were for opioids, 30% polysubstance, 22% alcohol, 14% cannabis, 13% stimulant. So as we see lower income, there is a higher prevalence of opioid use in particular. Again, this really goes back to access and costs. And this has actually been pretty consistent in the data for several decades, but actually alcohol use and alcohol use disorder is lower among lower socioeconomic status. Middle class and upper class are much more likely to have an AUD, which goes back to our kind of commercial understanding of why 50% of patients entering treatment have an AUD, because most providers take commercial insurance, and middle and upper class with commercial insurance are more likely to have an AUD than other drug use disorders. Looking at ages 17 to 64, 5% of Medicaid enrollees struggle with an OUD, particularly in rural areas. So putting all those numbers together, if we look at really the overall Medicaid market, and this is including MAT clinics, so we'll look at those separate in a second here, but it's about a $4.5 billion market cap, right? So if you got $8 billion for commercial insurance, and another 4 to 5 on the Medicaid side, that gets us to that $14 billion number that SAMHSA has identified. In our view, I wouldn't even say in our view, it's pretty objective. There's significant opportunity to increase Medicaid expansion. So Medicaid has expanded benefits, right? Most states have done Medicaid expansion, and then the residential opportunity that exists. So there are a lot of opportunities from a market growth standpoint where no one's servicing the Medicaid population because they haven't been set up for it. Medicaid didn't allow it. Their cost structure is not possible, right, with how high they operate for commercial insurance. So the providers that are getting ahead in the Medicaid demographic area have a lot of opportunity, and we see a lot of opportunity across the country to expand Medicaid services, especially at the residential levels. All right, so just looking at the opioid use disorder market as a subset of Medicaid in general. So most individuals accessing MAT services are on Medicaid. Just tends to be higher rates of OUD among Medicaid recipients. Again, goes back to that access issues we already discussed. So according to Fortune Business Insights, it's about a $2 billion market as of 2020. This is in line with everything that we've seen within the space consistently. If we look at what SAMHSA sees in terms of utilization rates, we can see that in 2019, massive increase in use of methadone, right? Individuals receiving methadone, 637,000 in the year 2019. Buprenorphine, or Suboxone, as you'll often hear it called, is 746,000. So a much higher number of individuals receiving Suboxone. We'll talk a little bit about why that is and what the market opportunities are there in a second. So what is the market cap for MAT programs as a subset of addiction treatment providers in general? And again, most MAT programs are Medicaid, so they're often a subsection of Medicaid. So overall, largely Medicaid. 2.3 million Medicaid recipients with an OUD. So that's what's been identified. About 50% of those receive treatment. So pretty high utilization rates, right? So if you've been diagnosed with an OUD, about 50% of people on Medicaid will actually use their services for that. So very high utilization. We really feel that that'll probably grow at least a bit over time. And we saw that with the numbers data previously that we just looked at with SAMHSA. The average length of treatment time for an OUD with an MAT provider is 5 to 10 years. However, that is not at a single facility. So there's a high propensity of individuals going to MAT clinics to bounce to different providers. So while they may be, accessing services for a 5 to 10 year period, they tend to be with one provider for less than a year. It's about a $2 billion market cap. We looked at that already. So now we want to break that down. So there are actually two separate business models that exist within Medicaid and MAT programs in particular. You have your OTPs, with their federally regulated opioid treatment providers. And for the most part, they dispense methadone. Now, they can dispense Suboxone or Vivitrol or anything else, but the vast majority of them do mainly methadone. And so it's a separate business model because they're coming in for daily doses. When you have an OBOT or an OBAT with an office-based opioid treatment program, those programs are more likely to provide Suboxone as a script or a film. So individuals are coming in every couple of days and every couple of weeks and maybe even once a month. So they do not need to be in the facility every day for the OBAT model, which is very different from methadone where they're coming in daily. So let's take a look at that. So according to the data that we've seen from Medicaid Q and other sources, is about 637,000 patients that are accessing 1,600 OTP clinics across the country. And these numbers have grown. So in 2020, I believe there was 1,800, I think it was like 1,847, if I remember right, number of OTP clinics across the country. There's pretty rapid expansion. There are some large providers in the space, Baymark, Community Medical Services, BHT, Crossroads. Like these guys are aggressively expanding. Acadia. 90% Medicaid plus. I mean, really the vast majority of methadone is Medicaid. Average reimbursement is $400, $420, so around $410 per month for a methadone patient. And so that comes out to about $5,000 a year in terms of total reimbursements for those patients. Retention is low. Again, within a single provider. Now, retention maybe within a methadone program overall might be high, but most OTPs lose 25% of the patients within the first 3 months and then 50% by 6 months. There's a median of 10 months across some different providers, but really that's because you have some people that stay 3-4 years, right? And then some people that are leaving in a much shorter period of time. So very high rate of attrition within OTPs. The average length of stay at a single provider is 130 days. I mean, that's according to Medicaid data on utilization. So market cap's around 1.2 billion. If you look at the number of patients, 637, you got your $5,000 reimbursement, but really they're only staying about 130 days on average, and so that comes out to a $1.2 billion market currently. Margins are pretty variable. You can, we see providers getting as low as 20%, and then we see providers getting as high as 40%. It really comes down to streamlining the platform and operations, as well as additional billing services that are being provided or what bundled rates are being negotiated with providers. If you are just dosing, if you're just providing methadone, frankly, there's higher margins than if you're providing more wraparound or comprehensive services. However, in our view, the payers and the communities are really looking for more wraparound services. So it's 40% margins is pretty unsustainable in our view over the long term, especially as more comprehensive providers come into the marketplaces. Just to understand like the numbers and the economics of it, most providers will be about 300 patients. You can get up to 800. We've seen over 1,000 in a single OTP. They're pretty unwieldy to manage. It's very, very hard to have that kind of patient volume from a logistics standpoint in a single building. Tends to be much more successful if you have multiple small buildings. Startup costs are not bad at all, really, at the end of the day. Right? You can do a de novo build for $500,000, and most people will start to break even within a little over a year. We see it range from 13 months to 20 months. It really depends on the provider and the structure and how they really do their acquisitions or their de novo builds. But that's the norm is $500,000 startup costs. You'll break that even as you hit a steady state census within somewhere between 13 and 20 months. OBATs, So 746,000 patients in 2019, as we saw. It's a mix of MET clinics and individual physicians. So there is definitely a trend towards more individuals accessing it through a clinic rather than an individual physician, mainly for the wraparound services and just ease of access. Individual physicians can only take on maximum 100 patients. It's unlikely that they're actually going to see that many in a given month because they're kind of moonlighting, or it's not their main thing that they do. They're still a physician, PCP, and then they'll do that on evenings or specific time during the day. So there's just not as much access to individual physicians. Average reimbursement, pretty wide range on this actually. A lot of people have different models. Some offer IOP, some don't. Some require them to come in multiple times a day or multiple times a week for their first couple of weeks. Some will give them a 2-week script right away. So very, very high variability on reimbursement, but we average that out about 1,900 per year. It can go, we can see as low as 1,200 to as high as 3,300 per year per patient, depending on the provider. OBOTs are similar to OTPs. They lose about 50% of their patients in the first 3 months on average. We do have clients that have an average retention rate of 1 year. Again, it goes back to the quality of the services and how happy the patients are with treatment and a lot of other factors. So high variability. There's not a lot of standardization within the MAT clinic space right now. And so because of that, you see a high variability in terms of how operators work, how patient volume exists, what reimbursements are like, etc. Market cap about 1 billion, right? So we have about 1.2 billion for OTP, 1 billion for OBAT, which gets us to our $2 billion number as an overall. This is less Medicaid, so it is more possible to see individuals come in from middle class and using commercial insurance. So you will see sometimes up to a 60-40 split. It still does tend to trend much more Medicaid, and I'd say we see a lot of facilities that are 80% Medicaid. It's just not uncommon at all. But you will see somewhere it's like 60-40. Again, margins are highly variable based on the topics we already covered. You'll see anywhere from 300 to 600 patients per clinic. Much easier to manage than OTP, right? OTP, I need people in every single day. So high volume, high traffic. At a Suboxone clinic, OBAT, they only have to come in, once a week, maybe once every couple of weeks. And so much easier to manage logistically. Also, startup costs are much lower. I mean, literally, you can just really have a doc in an office if you really want to get super bare bones. That's really not recommended. Again, the better providers are providing case management services, providing strong counseling services. But if you just need to get set up with a doctor that's able to provide scripts, 50,000 startup costs and 6 months to break even. Now, both OTPs and OBOTs are a very, very immature market. There's almost no marketing. Literally, what a lot of these facilities have done historically is they open up in an area where there was no competition, where there are no previous providers, and eventually through slow word of mouth, people find them. So we'll see often like a 3% patient growth rate month over month. And so slowly but surely, they just get more and more patients. And then they tend to hit a steady state census. Often that number is around 250 to 300. You'll just see kind of a cap where the number of new patients coming in equals the number of patients going out. Lots of different reasons for that. We can get into that into another presentation. But most providers are not spending anything on marketing and just letting it slowly grow. Now, if you do spend money on marketing, you can ramp that up much faster. Right? There's a lot of patients that are searching online that search Google. There's also a very strong demand for services in many areas, and people don't know that they exist. So to wait on word of mouth takes, on average, we'd say about 5 times as long. It's very possible to spend money and get higher patient volume into the facilities quicker. From a business development, community development standpoint, that's much harder. There's a lot of bias against MET clinics, and so there is very, very strong referral volume from hospitals, from jails, from probation offices, etc. But it takes a while to build those relationships. Okay, so looking at telehealth, just want to do a brief kind of foray and exploration into telehealth because it is a very hot topic. We see a lot of interest. We see a lot of providers that have sprung around it. Talkspace, BetterHelp, LifeStance really did the telehealth push for quite a while. And as we've also seen, a lot of those are unsuccessful. So Talkspace, significantly devalued, lost about 70% of its value not too long ago when they reported that they were not able to achieve profitability based on the current model. LifeStance has communicated something similar related to their telehealth components. We see Teladoc. Teladoc is 20 years old as a company now and has not been profitable in all of that time. So telehealth is not the panacea that I think people thought it would be. It's it's not even close to the opportunity that people thought it would be. There is a very big challenge in terms of client acquisition, client retention. In the telehealth space, a lot of our clients, when COVID hit, kind of thought they saw an opportunity to become a regional or a national level provider by providing telehealth services. And I can tell you for a fact that that has not been the case. So we have done telehealth marketing for quite a while, even before COVID, and it is a challenge. And when our clients really pushed for it, we were a little bit hesitant and recommended, not going very hard into the telehealth component of things. A couple of our clients did, and they were not very successful, just as these pure telehealth plays have also not been very successful. So why is that? Where is the challenge? And where is the opportunity in telehealth, if there is one that exists? Intensive versus outpatient is very, very different. So intensive, if I'm talking about residential levels of care, PHP, or even intensive outpatient levels of care, patients really, for the most part, prefer inpatient treatment, right? No one wants to sit on Zoom for 8 hours a day or 6 hours a day of clinical sessions. There is a very, very strong value in the human element of group therapy in particular. And so people really do like having the environment. They do like having other people there. Isolation is a big problem within addiction and behavioral health issues. So being isolated at home is not necessarily conducive to good recovery. Once we get to IOP, or intensive outpatient levels of care, we do see sometimes a 50-50 split. Now, will this continue? I mean, a lot of it is around COVID hesitancy. There's some fear around being in person settings, right? And really what we think and what we see, again, based on previous data as well, is that most people will want to be in person for intensive outpatient, which is about 3 hours a day of services, right? 3 to 5 times a week. And the reality is that there are some people that will always take advantage of it. Maybe they live really far away, they can't feasibly go to an intensive outpatient in their area. But most people do tend to prefer it. So we think that volume might change to like 70-30 once things with COVID kind of settle down. Um, there is a difference with outpatient. Now, if you're going to traditional outpatient, once a week to see a therapist, give an example, we work with one of the largest behavioral health providers from an outpatient standpoint in Seattle. And the last thing I want to do is spend 45 minutes in traffic to go to an hour meeting with my therapist and then 45 minutes home, right? That's time consuming, it's exhausting, it's not something I want to do, especially just for once a week. And if I'm going to once a week therapy, I don't have a high level of acuity, I don't have a high level of severity. This is just something where I want someone to talk to and hopefully help me through and build some different CBT skills, etc. So pure outpatient, 1 hour a week, maybe 2 hours a week, will absolutely utilize telehealth services. Very possible. Now, does that mean that that individual or that organization is going to be able to work nationwide and do patient acquisition? Very, very different story. Our Seattle client, for example, is extremely successful, but they have an amazing reputation in the space or in the community, and have had that built up over the past decade. So everyone knows who they are. Everyone knows they provide quality care. People know what they're about. They're not just advertising telehealth services. They're saying, hey, we're providing therapy services, and if you want us to provide telehealth, as an option that's there, people will take that option. They already built up the reputation. They already have the marketing engine in place for patient acquisition. The more focused you are from a marketing standpoint, the easier it is. So when you are really looking at building a successful organization within the healthcare space, it comes down to quality and differentiators, which we'll touch on a little bit later. But you can't just offer telehealth services and say we offer telehealth services. It's not just about meeting demand with supply. It's a very, very simplistic business model. If people were hungry and then I could go sell hamburgers, right? Then I could build a McDonald's at any moment in time. People want coffee, right? But I can't open a local coffee shop and become a Starbucks. There is a massive difference between building a successful business when we just have a supply and demand dynamic versus really focusing on differentiation, effective execution, right? And so when we look at telehealth, there just are no differentiators, right? Everyone's just connecting patients with therapists, and that's all it is. And so why would I use BetterHelp versus Talkspace versus LifeStance? There is no reason for me to choose one or the other. And so for that reason, you're never going to have differentiation in the marketplace and create any kind of defensive moat around the business. You really just can be competing with everyone. to hopefully get one patient to choose you versus the other. There's this kind of thought process around, well, if we can get enough first mover advantage, market penetration, where we become the go-to, then we'll establish this kind of dominant moat just by default. That's not how it works, right? It's not about having the most reach and people being aware of you. It's really about having a reason to go with one provider over another. And that's what I have not seen in the telehealth space at all. And that's why a lot of them are failing. There's a very high cost for patient acquisition. Again, just like any other long-term behavioral health or addiction treatment outcome, um, turnover is very high. So, you'll see as many as 25% of patients in an outpatient setting won't show up to their second appointment. So 25% turnover for a week, it costs quite a bit to get a patient, right? I mean, if you don't have a reputation, if you're just trying to go out into the middle of nowhere, and someone that's never heard of you and acquire them as a patient, you're going to pay at least $500 for patient acquisition. Well, you're only getting reimbursed, 100, 125 for a session. So if I have 25% of my patients leaving within the first week, that means that I'm paying, a lot of money to acquire patients and not getting that cost recouped. And that's just the first week, right? There's a high volume of patients that stop going after 3 months, just like we've seen with MAT clinics. So that's why you see some of these telehealth providers that are having mandatory payments of $500 up front to actually enroll in the program. So their assumption is that they'll at least break even on the marketing cost, if not the labor aspect and the infrastructure aspect of things. But it's a very, very high cost per acquisition per patient right now. So I don't really see that changing anytime soon. And especially from a telehealth perspective, like if we're looking at SUD, right, acquisition costs for SUDs are very high. It's $2,000+ for like a residential level of care. And at the end of the day, that's really a lot of what you're competing with. Based on the auction system and the number of providers in the marketplace, whether you're providing outpatient services or intensive inpatient or residential levels of care, you have that same cost structure, unfortunately. And so it's just not sustainable from a pure telehealth play because your reimbursement's not there for it. Step downs is actually a really great way to use telehealth. So, we're talking about telehealth has a challenge working with intensive settings, right? No defensive moat, high patient acquisition costs, but telehealth is a great opportunity for step downs. If I've already got you in my continuum of care, in my system at a residential or PHP level, there's a high probability you'll be willing to step down and you actually retain more patients because a lot of patients might not live near your residential, right? And you might not have an IOP in the area where they live. So by offering a telehealth option for step down, you can actually retain more patients and have higher step down percentages than you would if you did not have a telehealth option. So that is actually one of the benefits. But again, that's not a patient acquisition. That's a continuation in the continuum of care so that you're actually extending your, basically incremental revenue at that point. So that's a broad overview of the field. It's a broad overview of where patients can potentially come from, what the market caps are, what patient volume looks like, at different levels of care, different provider types. So what are the trends in addiction treatment that we're really seeing in terms of which of our clients are successful, both locally as well as nationally, which are the ones that are struggling? There are a number of trends that we really see the space needing to examine when they consider either market entry or growth opportunities. First one is healthcare is local. At the end of the day, healthcare is local, and there was a misunderstanding in the space for quite a while because the dynamic was different. There weren't enough providers, there was a lot of demand, very little supply, so people were absolutely willing to fly to treatment in a different locale. They'd come from New York and go to Florida. The reality is that that model is completely unsustainable long term. There's not a lot of growth there. There are certain providers that are still existing on a pure out of network basis because the margins actually aren't that much better. But the reimbursement is much better, so you can pay significantly higher in terms of marketing costs. So it's okay to pay $7,000 to acquire a patient because my reimbursement is going to cover that marketing spend. But at the end of the day, my cost per acquisition is going to reduce my margins to the standard margins of a network provider. There are not nearly as many patients. The reason for those higher costs for flyaway treatment is that there are not nearly as many patients that are willing to fly. They're not willing to pay a high deductible to go somewhere they've never heard of in another state. And this is super consistent. If you look at our data, if you look at, I think, any data that might be out there, the vast majority of patients for a residential provider come from within a 150-mile radius. Actually, oftentimes about 70% of the patients will come from a 70-mile radius. So, even the majority is coming from a smaller radius for residential levels of care. And then at lower levels of care, especially if you're looking at like intensive outpatient, for example, or outpatient for sure, 10 to 30 miles is the max. MAT clinics are the same because I have to go every day or I have to go multiple times a week. I'm not going to a facility that is distant from my home. So healthcare is absolutely local, and that includes substance use disorder treatment. Cost-effective extended care is the opportunity of the future. So a lot of providers have avoided this. They really like the decent margins and the lack of logistics and complexity that exists within a residential facility, and very understandable, right? I can have a low patient volume. I only have to find somewhere between 30 and 100 patients a month, depending on how many beds I have, and that's very easy to do compared to having to find 1,000 patients a month to fill an outpatient program, right? Even if I'm doing intensive outpatient, that is easier to fill because patients are staying longer term. They're much more willing to come into a lower level of care. That is, one, it's cheaper, or two, it's a lower burden on their time, right? They can do it after work or after school or whatever. So cost-effective care that's extended is really the future of addiction treatment. So it's a full continuum of care. And this is also what the payers are looking for. So I've had very direct conversations with the heads of SUD behavioral health departments of the larger payers in the country. And some of them have told me that if we could, we would not pay for residential. We would just completely cut that out because we don't think it's effective at the cost that is being, requested of us. So why do they even have residential then? Well, at the end of the day, the big employers are the customers of the payers, right? And the big employers expect residential. There is an assumption that higher levels of care are more effective. Now, this isn't quite borne out in the data per se, and the payers are very aware of this. So the payers would be happy to see that cut out completely. Now, you will have providers that complain and say, hey, look, the payers aren't willing to reimburse us, yada, yada, yada. The reality is the payers are happy to pay, right? They'll pay for MAT for years. They'll pay for outpatient counseling for years. The payers have no problem paying for long-term care. What they are very disinclined to pay for is, $15,000 to $30,000 a month for high-intensity care that they don't see being overly effective at the end of the day. And so the reality is we'll talk about this, a lot of clinical outcomes that prove it either way. So why should they pay more? So if you really want to build a successful program, it's building a full continuum of care and figuring out how to have high volume with low reimbursement at lower levels of care. That's what the payers want to see. That's what patients want. And that's also what the clinical outcomes data shows is effective. The longer they're connected to care, the more successful, the more likely that person is to be able to find long-term recovery. Mental health, huge opportunity. There is a very strong movement among professionals, researchers, even the payers to recognize that addiction and mental health are really, might not even say two sides of the same coin, might say it's just literally the same side of the same coin. For a long time, addiction treatment and behavioral health developed along different trajectories within the US for historical reasons that we don't need to get into here. That convergence is changing where they're actually coming together. And so the payers in many states don't even care if you bill primary addiction versus primary mental health. They're just saying, hey, look, treat this patient, help them out. So co-occurring dual diagnosis is just becoming care for patients' behavioral health issues. There are almost 4 times more people struggling with overall broad mental health issues, right? Depression, anxiety, OCD, bipolar, trauma, PTSD. So there's much more opportunity within the mental health space than the SUD space as well. And we saw this with the market cap data, right? So as a specialty provider, we're looking at 14 billion as a market cap. And that was 42 billion for substance use disorder treatment in general when we added in pharmaceuticals and hospitals, et cetera. Now that is out of a $238 billion mental health market, right? So again, there's 5 times more revenue in the mental health space than there is in addiction treatment. So a trend is really combining these two types of treatment and provisions for care. Clinical outcomes is one of the largest opportunities in the space. There has been some movement recently to make this work. There are third parties out there like Track9, for example, that is really trying to build models around effective treatment and modeling what that looks like and helping build feedback loops so that you have patients getting care in the facility as well as tracking them outside the facility. More and more, NATAP just created a whole different kind of analysis platform called Foresight that they were trying to build out to do something similar. So there are big initiatives, but this is what people want to see. As a consumer, I want to see effective outcomes, right? So I can make a intelligent and informed decision about where to send my loved one or where I should go for treatment. The payers really want it as well. And then if we're looking at value-based care, people need it for an outcomes model, right? What's the likelihood that a patient that we have in our facility is going to come back to us? So how can we build that downline risk into any kind of value-based care contract? So clinical outcomes are absolutely essential. There's tons of opportunity to do them better and to build mathematical models around them to understand what's going to work and what's not going to work. Differentiated value propositions is also probably one of the number one problems in the space that we don't see being addressed. So when we look at the larger providers in the country, why would you choose one versus the other? And the reality is that not only can consumers not answer that question, but internal staff can't answer that question. And so there has to be a reason for us to choose a Toyota versus a Chevy, a McDonald's versus a Burger King. You have to have some kind of value proposition in place that says this is why you should go here. So to build a national model or even a regional model, that's what has to be there. And this is where most providers have really failed. So most providers are just still providing, hamburgers is kind of the way that we often characterize it. It says people are hungry, let's feed them hamburgers. Well, that's not going to motivate me if I see that from a marketing standpoint. If I hear word of mouth in the community, if they're, well, okay, I have an addiction and they provide addiction services, who cares, right? That's not helpful to me, especially because I have so many options these days. There is almost no communities in the US that do not have multiple addiction treatment providers and multiple behavioral health providers. So you have to give people a reason to choose you. And often that's quality, right? Quality can be one of those differentiators, but it doesn't have to be. At the end of the day, I don't go to McDonald's because it's the best burger in the world. I go because it's fast and it's fairly cheap. And that's what I'm looking for, right? If I get a bad experience at McDonald's from a service standpoint, I'm usually okay with it. I'll still go back to McDonald's at another time because I'm not going there for quality service, right? So really high clinical outcomes and quality is super important as a potential differentiator, but can you serve people cost effectively, right? That is a huge value proposition for a lot of people because deductibles are so high, because insurance policies are having more co-insurance. If you do cost effective care, that's highly valuable to the payers as well. You provide extended care. That's a very strong differentiator that is very valuable to people. Do you provide specialized care? If you're providing a veterans program, are you just putting them into the general population program, or do you actually have trained clinicians that actually understand the unique struggles of veterans and how to help and support them? So differentiated value propositions is the number one opportunity that we see existing in the space that no one's really done. Most people are really trying to just get in front of patients and meet supply with demand. And you're never going to build a regional or a national business model off of that. Once you have differentiated value propositions, then you can do community and alumni referrals. They become much, much stronger. The most successful clients that we have very, very heavy community referral relationships and especially alumni networks. If you look at older providers, a lot of the nonprofit community, those clients have up to 50% of their patient volume comes from their alumni network. And so that comes from the relationships that they've built, the quality of care that they provide, the quality of extended services that they provide. So lots and lots of value to a differentiated value proposition, not just from initial client acquisition, but from long-term relationships and referrals that come from serving previous patients in a very strong, differentiated manner. Risks to avoid. There are some key risks that I think we still don't really see as well understood in the field. Non-urban locations are a big risk. It will cost you more money and it will be harder to acquire patients the farther out you are from an urban area. Our clients that are in urban areas, it's just much, much easier to acquire patients. People are willing to go locally. Now, it doesn't mean that when they want to go in their same zip code, right? Because they might not want to see some of the same people. But, if you're in a suburb outside of a major metropolitan area, very, very easy to acquire patients versus being a 2 or 3 hour drive out in the boonies. It's just very, very hard to acquire patients and market and build community relationships. You also have a recruitment issue. So our providers that are in the middle of nowhere, well, there's no talent, right? There are no therapists that live in these small rural communities. So that means you've got to get someone that's willing to move there, which is very difficult. or you got to get someone that's willing to drive, 30 minutes to an hour to work every day, which is also very difficult, especially with the level of competition that now exists for therapists and nurses and other individuals within the behavioral health profession. So really strongly recommend non-urban locations for treatment providers. It is one of the larger struggles that the older models have been facing for quite some time. Widely dispersed footprint, very similar. It's very, very hard to manage, facilities across the country. You got to fly around. You've got to deal with different payer environments. You have to deal with different consumer environments. It's harder to standardize, and then it's much, much harder to market. The more concentrated you are from a marketing standpoint, from a focus standpoint, when it comes to leadership, the easier it is to expand. So if you look somewhat at some of the most successful providers in the country, right? You got your Pyramid, you got your Pinnacle, you got Granite Recovery, right? These providers are highly concentrated, and so they have been very successful, both from a growth standpoint, but also from an EBITDA standpoint, right? They're making very good margins where the providers that are spread out really, really struggle to make that work. Non-diversified marketing is still a massive issue in the space. So most providers are still highly reliant on just Google, really at the end of the day, whether it's Google Ads or search engine optimization. There is huge opportunity to build a really robust diversified marketing strategy. And our clients that use a diversified strategy are far and away the most successful. The challenge here is that you can no longer do a one-to-one tracking from a final attribution standpoint. So a lot of executives, and especially even on the private equity end, we have a lot of people that love their spreadsheets and they want to see the click and the call and the admission. And so if they can't see that, they don't really understand how to build, a more complex multi-channel journey, omni-channel model for attribution. And so there are many points along the patient journey. A lot of patients are not searching on Google. A lot of patients are not going to a hospital or another provider. So to really reach patients across the board, you have to be advertising on Facebook, on LinkedIn, on TV, maybe even on some radio. You have to be involved in your communities. You have to be building relationships across partners in those communities. Without a diversified marketing strategy, you will not be able to get cost per acquisition down. And we've seen this again and again and again. It becomes a vicious cycle where providers are not able to fill their census, so then they pour more money into these final attribution channels, such as Google Ads or business development, and then the costs are too high, it's not sustainable, and so they reduce it, and it's a mess. You've got to commit to a really diversified marketing strategy, and that will absolutely bring your cost per acquisition down to $1,500 or less for an SUD provider. Lack of clinical differentiation, we've already talked about. If you're just providing treatment as usual, if you're just selling a hamburger and that's all there is to it, is not something that is going to allow you to grow. So providers, again, struggle with this because a lot of executives are not clinicians themselves. They understand the numbers, they understand marketing, they understand sales, they understand costs, right? But clinical differentiation is absolutely the key to growing a large, successful organization. So if you don't have clinical differentiation in place, you're really going to struggle. We'll just say very definitively, you will struggle 100%. We have not seen a single provider that does not have clinical differentiation in place be able to grow and scale profitably and successfully over the long term. In fact, a lot of providers end up just closing down because they get beat out by a provider that comes in and does provide some kind of differentiated care. So where are the opportunities then? There's a couple. So underserved markets always comes up as a question. Well, we just want to go in again, this whole supply demand conversation. Where is it not saturated? Where are there not providers? This doesn't really exist anymore. I mean, there are places in the Midwest, there are places in the Northwest, where there are a lack of providers, but the reimbursement structures aren't great there. The patient volume, population density is not great there. And so they are underserved markets for a reason. So we don't recommend trying to build a business model around, either trying to find the best payer rates or trying to find places where other people aren't. The real opportunity that exists right now is becoming a provider that provides better quality or differentiated clinical care than anyone else in the community. You're not going into a community that doesn't have demand and meeting it. You're going into a community where there are other operators that are already supplying services to meet the demand, and you're going to provide better services, you're going to provide differentiated services, and you're going to steal market share from others. So that's really where we are. We're in a much more mature market. This is especially the case for addiction treatment, But also for MAT clinics, it's starting to be that way very fast. So MAT clinics did exist in a little bit of a vacuum where they were able to just go in and meet demand with supply and fill up. But as we're seeing, just like we did with addiction treatment, just like we did with psych hospitals, there are becoming multiple competitors in the same communities and the same geographies. And so you are no longer able to just meet supply with demand. And you have to make sure that your patient volume stays high by providing differentiated or quality care services, because otherwise what happens is there's no moat. And when another provider comes into the space, they steal a bunch of your market share. So really, really focus on saying, okay, how can we go into this market where there are existing providers and how can we do it better, right? What are we be able to do differently that is going to make sure that we take a large share of that patient volume away from existing providers? Where there is opportunities, Medicaid. So again, based on cost structure and just the logistics and lower margins, people have been less willing to target Medicaid. So there's a lot of Medicaid opportunity across the country. You can absolutely open up a residential provider or IOP services and serve the Medicaid population and fill that up without having differentiated services. Again, that's a short-term thing. It's just a first mover advantage. So we strongly recommend having a very strong program that so as you build that patient base, you become known as the best provider or the right provider to go to when competitors come in, because they will. Eventually, people will move into these Medicaid markets. They will not have the ability to steal patient volume as much once you've built up a really differentiated quality model. Clinical differentiation, we've hit 100 times. Aggregation of best practices is part of this. This is what we see missing in a lot of providers. And this is the same thing if you look at some of the largest behavioral health holding companies across the country. Are they known for best practices? Are they aggregating clinical outcomes or what works best across their facilities? And their answer is no. Most of them are not. They really just operate as holding companies where each facility kind of does its own thing. And there is no feedback loops in place to say, okay, this is what works and this is how we build better clinicians. This is how we build better programming. This is how we get better results for patients. None of that has really been defined at any of the previous holding company models or even the existing holding company models. So to come in and aggregate clinical data and build a feedback loop and then build best practices for the field from a clinical standpoint, huge market opportunity, huge. That also reduces your marketing costs over time. So there's often a large understanding or misunderstanding when it comes to what brand is. There's this idea that brand is about marketing, and if we get it in front of enough people and we build a brand, that's not true, right? That's not what happens. Brand is your reputation. That's all it is. And so reputation is built through differentiated or quality products and services. So a really easy example of this is buying a used Toyota versus a used Chevy. So which one are you willing to pay more for? 100% you're willing to pay probably twice the amount for the same year and same mileage for a used Toyota or a used Honda even than you would a used Chevy. And the reason for that is, as we all know, that Toyota and Honda build cars that last. You will not have to repair that car. You will not have problems with it for 100,000, 200,000 miles, right? Where the Chevy, you're lucky if you get half that mileage out of that car before you've got some massive repairs. So it's not the fact that marketing went out and built out this idea that Toyota is a better car and lasts longer. The reality is that Toyota builds a better car that lasts longer. So marketing communicates that message effectively, and you optimize those spends to make sure that you communicate it to the right people at the right time in the most cost-effective manner, but you are amplifying the product or service qualities that already exist. Marketing is not making up differentiators that then somehow get believed by the consumer base, right? It really comes down to what is the quality of the product and the service. And that doesn't matter if we're talking about cars or we're talking about addiction treatment and behavioral health services. You have to have a really quality or differentiated project. Then marketing communicates that out and amplifies that messaging into the communities, and those match, right? That message that's in the community must always match what's being delivered. Otherwise, you have a negative spiral spin and you actually hurt your business by communicating something that you're not delivering. Then people get angry, you get bad online reviews, you get bad word of mouth. People no longer believe what you say when they do see marketing messages from you. So clinical differentiation leads to brand, which is just reputation, which reduces your marketing costs over time. As you build up trust within the community, They are more likely to take action. They're more likely to click. They're more likely to call. They are easier to convert on the phone. So all of your metrics increase in a positive way, reducing your marketing costs. You also reduce those costs because people are already aware of you and that reputation exists. So when you have a positive reputation, you get positive word of mouth. And that includes among community referral partners, not just consumers. And so you have a reduced marketing cost. So when I think of, for example, well, where do I want to go? Because I just moved to a new apartment and I need to fill up that apartment with fairly cheap furniture all from one place. Almost everyone's going to think of IKEA, right? So IKEA didn't have to pay money to get that message in front of me. I already knew that IKEA was a place that I needed to go to get a whole bunch of furniture for a reasonable price. So the marketing cost for IKEA is reduced because they have a good brand or reputation. And so really great brand reduces marketing costs over time. Concentrated footprint is huge. Again, if we look at Granite, we look at Pinnacle, we look at Pyramid, these really successful providers, the reason is that they're concentrated. They're very focused and they start off that way, right? Some of them have started to expand more and more, but the reality is that they were super concentrated in the beginning. This focused the leadership team. This made um, reimbursements easy from a clinical standpoint in terms of getting relationships with the payers and figuring out that whole network and system. It builds it from a marketing standpoint. I can concentrate my spend in a very focused area, which makes it much, much easier to build a reputation because everyone knows who we are and we have to spend less money to reach less people at the end of the day. Okay, streamline operations as well. Like I said, from a leadership standpoint, if everything's concentrated in one single area, we can build back-end billing, back-end marketing, back-end communication structures, right? Back-end business development. Everything's just streamlined. If it's in a concentrated area, it's just much, much easier to do. So highly, highly recommend concentrating your footprint and then building streamlined operations because a lot of providers just kind of willy-nilly buy facilities or build de novos and they don't have a standardization. So there's no platform in place. It's really one of the struggles that we see. This provider here in Georgia is operating from differently from this one here in California, is operating differently from this one here in Florida, and that's highly problematic. Your costs are just much higher when everyone's doing something different. And again, you also can't build, really a clinical reputation. You can't build best practices because everyone's doing something different. So streamlining operations is a huge opportunity within the addiction treatment space. So that's it. I hope that was valuable for you. If you guys do have additional questions, I'm always happy to discuss those. Feel free to give us a call or send us an email at those numbers below. Again, my name is Nick Jaworski. You can connect with me personally on LinkedIn if you just want to connect with me rather than reaching out through the company. A little bit about us. So we have, as I mentioned in the beginning, over $2 billion in behavioral health data. As far as I know, more than anyone else in the space. We have a couple wings of the business. We have an operational consulting wing, a full service marketing wing. Do a lot of data analytics around those. Within the operational consulting, it's turnarounds, so providers that are struggling or something's kind of gone wrong, we come in and help fix it up. And that's everything from call centers to business development to overall strategy to P&L utilization of where you're spending your money on what and why. Growth strategy is a big one since we work with the largest providers in the space as well as smaller ones just getting started. We've seen it all across geographies and level of care. So we really understand how to help someone build from one facility to three, from three facilities to five, from 5 to 10, etc. We do a lot of due diligence for people looking at acquisitions and then exit strategy on the flip side for owners looking to leave. So how do we make sure that your business is set up to be ready for you to exit that, or how do we make sure your business is set up to be acquired by someone else? Full service marketing, web design, development, search engine optimization, paid media, which is your PPC, your Google, your Facebook, your TV, your radio, social media, content writing, graphic design, email marketing. The bottom line is what we do because we have the operational consulting wing as well as we are strategic partners. We're not vendors per se. We really help clients define and execute a strategy rather than relying on them to come up with it. We know the answers. We've got the data. We've done this a million times. We know what works and what doesn't work. And we know how to tailor that message to be specific to the client. So at the end of the day, I can't go and build a coffee shop and become a Starbucks, right? Just because I know how Starbucks markets, you have to have those differentiators. We have to know what works for you and your communities to be able to create really specific marketing strategies across those channels. And again, it has to be multi-channel. So we really focus on strategic direction in terms of what's going to work. And we're constantly iterating. We're very agile in terms of getting results for clients. because at the end of the day, what works today doesn't always work tomorrow. What works in Georgia doesn't always work in Florida. What works with this provider doesn't work with that provider because they're a different program and they have different strengths and different weaknesses. So very, very tailored on the marketing aspect of execution. We've got 30 full-time staff at this point. Everyone is based here in the U.S. We're based in Indianapolis, Indiana. We range in terms of clients from people doing 5 million a year on the low end to people doing $1 billion a year in revenue is our largest client, right? So we again can really help people move between those levels if they're trying to grow, and we can also really look and understand drilling down what's maybe not working with an individual facility if we're just trying to focus on one facility versus the organization as a whole. We work with traditional drug treatment providers, addiction treatment providers, MAT clinics, like hospitals, outpatient behavioral health. So anything within the behavioral health space is our expertise. We know the space inside and out. We know how to get results. So always happy to talk to anyone that wants to have a further conversation on just overall market dynamics or what we could do specifically for you as a provider. Appreciate your time. Until next time.